I don't care if this is the best drug on planet Earth. As we know from our experience in the metastatic setting, trastuzumab deruxtecan specifically has been associated with significant rates of interstitial lung disease, low but clinically important rates. It requires a different level of monitoring and management. So physicians and patients need to be comfortable with in my mind, the increased intensity of follow-up, which isn't really what we would do normally. We don't normally do serial CT.
Sure. In this study, they did a CT at 6 weeks, I believe. And so that would be something that would be extra. But interestingly, the interstitial lung disease rates were similar in both arms, maybe because it is only 4 doses of TDXD. So
to my recollection, there was 1 fatality in each arm. And the fatality in the trastuzumab deruxtecan arm, I believe, was ascribed to interstitial lung disease. But again, ACTHP comes at a cost too, and there was a fatality in that arm that was ascribed to therapy too.
Correct. The nausea rates fairly similar, which again, an anthracycline. So I do feel like substituting out TDXD for an anthracycline, they're both pretty toxic drugs. I think the real question lies, in is there a space or a place for, less intensive therapy? What do you think about switching it up and doing a taxane HP first as a lead-in? Do you have any thoughts about that?
Well, it would be purely speculation because I don't have any data to support any hypotheses there. I do think that just to your last point, I do think that the preemptive toxicity management is incredibly important. So it's not just ILD, but the nausea and vomiting can be real. So I inherited someone from the DB01 trial who was on trastuzumab deruxtecan for over 7 years for metastatic disease. Every time that she came in, we would talk about whether we should switch her to just trastuzumab alone or trastuzumab and pertuzumab. And then we always thought, well, if it's not broke, don't fix it.
I understand that.
Because she had no nausea. It was incredible. She had no side effects whatsoever. And then I had another patient who, after the second dose, again for metastatic disease, said, I don't care if this is the best drug on planet Earth. The nausea and vomiting for her was so terrible, she wouldn't consider continuing on.
Sure.
And that was despite 4-drug prophylaxis. So that preemptive prophylaxis is really important. Fortunately, most patients fall in the middle of those two. Those are 2 very extreme examples, but that building in that prophylactic regimen is so critical.
We've learned that over time with anthracyclines.
Right.
So perhaps in this neoadjuvant setting, we're going to need to think about that similarly, even with TDXD.
Absolutely. And this is a treatment-naïve group, right? Yeah. So they haven't had exposure to any of the side effects of any of our therapies to date. And so
they don't know how to use any of the drugs yet, even the supportive drugs.
Correct. Yeah. And so education is really important.